Welcome back to another Clarity Education Systems live session. I'm Dr. John Rossi, and I'm excited to have you here for another round of high-yield learning. Every session, we tackle essential practice questions, break down complex clinical concepts, and fine-tune your test-taking strategies, all with the goal in mind of helping you pass your PMHNP certification exam with confidence. So whether you're here to reinforce key topics, sharpen your critical thinking skills, or just stay on track with your studies, you're in the right place. So grab your notes, clear your mind, and let's dive into today's first question. Let's kick off today's session with a case that highlights one of the most critical aspects of psychiatric care, managing suicidality in schizophrenia. Understanding the best treatment options for high-risk patients can literally save lives. A 29-year-old male with schizophrenia has a history of multiple suicide attempts and persistent suicidal ideation despite being on optimal doses of Abilify and receiving cognitive behavioral therapy. He has no history of treatment non-adherence, but continues to experience severe distress due to suicidal thoughts. His medical history is unremarkable, and he does not have a history of agranulocytosis or significant metabolic complications. What is the most appropriate next step in management? Our options are A, increase the dose of Abilify to its maximum FDA-approved limit. B, switch to another second-generation antipsychotic with a lower metabolic risk. C, augment current treatment with lithium to target suicidality. Or D, initiate clozapine therapy. Take a moment to think about what sets this patient apart. He has treatment-resistant schizophrenia with persistent suicidality. Which option provides the strongest evidence-based approach to reduce suicide risk? Okay, if you selected D, initiate clozapine therapy, you absolutely nailed it. Let's break down why clozapine is the best choice for this scenario. So patients with schizophrenia are at a significantly higher risk for suicide, especially those with persistent suicidal ideation despite treatment. Clinical trials have consistently demonstrated that clozapine reduces suicide attempts and hospitalizations for suicidality more effectively than other antipsychotics. In fact, the International Suicide Prevention Trial showed that clozapine reduced suicidal behavior by nearly 26% compared to other drugs, solidifying its role as the gold standard for medication for suicidality and schizophrenia. Since this patient has already failed optimal doses of Abilify and is still experiencing distressing suicidal thoughts, transitioning to clozapine is the next logical step. All right, now let's go over why the other options don't adequately address the patient's risk here. So option A, Abilify is not FDA approved for suicide prevention, and dose escalation is unlikely to provide the needed protection. So the patient already failed an optimal dose, so increasing it further is not the best strategy. Option B, while medications like quetiapine or ziprasidone might have lower metabolic risks, ultimately, they lack the strong evidence for reducing suicidality in schizophrenia. Clozapine remains that superior option. Option C, lithium has well-established anti-suicidal properties in bipolar disorder and major depressive disorder, but its role in schizophrenia-related suicidality is not as well supported by the evidence. While it might be considered in certain cases, clozapine is the preferred first-line option for this indication. All right, so the key takeaway here is clozapine is the only antipsychotic FDA approved for reduction and reducing suicidality in schizophrenia. This case reinforces the importance of recognizing treatment-resistant schizophrenia and knowing when to transition to clozapine. So as PMHNPs, we must always be prepared to intervene aggressively when a patient's life is at risk. All right, awesome job on this first question. Let's keep up the momentum and head on to our next question. Okay, so this next case highlights an essential skill for PMHNPs, knowing when psychiatric symptoms could be caused by an underdiagnosed or undiagnosed medical condition and ensuring we stay within our scope of practice. The question reads, A PMHNP is working in a primary care clinic and is evaluating a 27-year-old patient with worsening panic attacks, significant weight loss, and persistent fatigue. The patient states they have not seen a primary care provider in several years. Upon assessment, the MP notes an irregular heartbeat and mild exophthalmos. The patient is requesting a medication to help with anxiety and sleep. What is the most appropriate course of action to ensure the NP stays within their scope of practice? Our options are A, prescribe a short-term benzodiazepine to manage the patient's anxiety symptoms while monitoring their response. B, initiate an SSRI for anxiety and provide dietary recommendations to address the patient's weight loss. C, refer the patient to an endocrinologist or primary care provider for further evaluation before initiating psychiatric medication. Or D, order a complete thyroid panel and adjust the patient's psychiatric treatment plan accordingly. Now think about the bigger picture here. What could be causing this patient's symptoms? Is it purely psychiatric, or could there be an underlying medical condition at play? All right, if you selected C, absolutely correct. Let's break it down now. So this patient represents with classic symptoms of the hyperthyroidism, right, which can mimic anxiety and panic disorders. So the combination of panic attacks, weight loss, fatigue, irregular heartbeat, and bulging eyes, this strongly suggests an undiagnosed thyroid disorder, possibly Graves' disease. So as PMHNPs, our role is to recognize when symptoms may be caused by underlying medical conditions and ensure that the patient receives the appropriate care. So initiating psychiatric medication without first ruling out a medical cause could worsen their condition or even delay proper treatment. So let's go over the other options here. So option A, now this fails to address the root cause of the symptoms, prescribing that short-term benzodiazepine. Giving a benzo could mask hyperthyroid-related anxiety, delaying necessary medical intervention, plus the benzodiazepine doesn't treat the underlying disorder. Option B, so while initiating an SSRI might help with anxiety if it were primary, it's risky to prescribe without first confirming and looking at the symptoms that aren't due to the thyroid dysfunction. So treating the wrong condition could lead to worsening symptoms. And then finally, option D, ordering lab tests. This very well may be within your scope as a PMHNP, depending on state regulations. But diagnosing and managing an endocrine disorder is not. So endocrinology and internal medicine providers, they should be the ones that handle the thyroid dysfunction, while you, the PMHNP, focuses on that psychiatric care. Okay, so key takeaway here, psychiatric symptoms, always rule out a medical cause first. This case reinforces the importance of staying within our scope of practice while ensuring patients receive the right care. As PMHNPs, we are the bridge between psychiatric and medical care. Our job is to recognize when a deeper evaluation is required. All right, great work on that one. Let's go ahead and press forward on to the next question. So this case presents a difficult yet pretty common ethical dilemma in psychiatric care: how to approach suspected elder abuse while respecting a competent patient's autonomy. So, a 75-year-old patient with mild depressive symptoms presents for a follow-up visit. They are alert, oriented, and independently manage their daily activities. During the visit, the patient's spouse is observed making belittling comments. Nursing staff have previously documented multiple occasions where the patient arrived with bruises inconsistent with their reported activities. When questioned, the patient confirms that their spouse often yells and sometimes grabs them forcibly, but insists that they don't wish to take any action or involve any authorities, stating, "I can handle this myself." The patient demonstrates clear understanding of their situation and the potential for the risks involved. What is the most appropriate action for the PMHNP to take? So our answers include: A, report the suspected abuse to Adult Protective Services. B, encourage the patient to leave the situation and provide resources for shelter options and services. C, initiate a mental status exam to determine if the patient is competent to make this decision. And D, respect the patient's autonomy, and provide education on available resources without reporting. This is one of those gray areas in clinical practice sometimes. How do we balance patient autonomy with safety? What would be the most ethical and legally appropriate response? Okay, if you selected D, great job. Let's unpack why this would be the best response, because it can sometimes be pretty confusing. So, in situations where elder abuse is suspected, the key consideration is whether the patient has decision-making capacity. So in this case, the patient is alert, oriented, and independent in daily activities. They demonstrate clear understanding of the situation and risks. They explicitly refuse intervention. Because the patient is competent, they have the right to make their own decisions, even if those decisions involve staying in a potentially harmful situation. As providers, our role is to first offer education on the signs and risks of abuse. Next, provide resources such as local support groups, shelter options, and safety planning. And then the third option could be that we want to do is continue to monitor the patient for any changes in the patient's safety or ability to make those informed decisions. So this approach really respects the patient's autonomy while ensuring they are fully informed of their options. But let's make something clear here. We're talking about a relationship, right? A husband and wife, or wife-wife, husband-husband, whatever the situation may be. This is different than if an elderly patient was being treated by somebody outside that relationship. In that case, elder abuse would apply, and we would need to notify the situation and the abuse that's occurring, because it's elder abuse under care, not elder abuse as it pertains to a relationship. Another situation that would make this different would also be if this were a child. In that case, we would need to call Child Protective Services, might need to get the authorities involved, because this is an underage individual and we need to be very careful when we're caring for them. All right, so let's go over why the other options aren't appropriate here. Remind ourselves of option A real quick. So in option A, we're talking about mandatory reporting here to the APS. So mandatory reporting laws vary by state, but in general, APS is required when a vulnerable adult is unable to protect themselves due to cognitive impairment or severe harm. In this case, the patient is competent and denies wanting intervention. So mandatory reporting does not apply here. Option B, while leaving may ultimately be the safest option, right? Simply encouraging them to leave without assessing their readiness can be counterproductive. It may create distrust, making the patient less likely to seek help in the future. And then option C, initiating an MSE. So the patient is already demonstrating capacity, right? By expressing and understanding their situation. This, the MSE, it's basically unnecessary at this point in time unless you notice red flags, suggesting that there's an impaired condition or judgment. These are not present in this situation or case. So cases like these, they really are challenging because we want to protect our patients, but we also have to respect their rights. The best thing we can do is provide education, resources, and continued support. So if they decide to seek help, they know where to turn. All right, great job on this one. Let's move on to the next question. And this question really touches on critical legal and ethical issues, protecting the confidentiality of substance abuse treatment records while ensuring coordinated patient care. The question reads, a PMHNP is reviewing a patient's records before coordinating care with a primary care provider. The patient has a history of opioid use disorder and is currently engaged in medication-assisted treatment. The PMHNP has a general release of information signed by the patient, but notices that it does not specifically mention substance abuse treatment records. The primary care provider requests access to the patient's full medical history, including details on past and current substance use treatment. What is the most appropriate course of action for the PMHNP? So our options include A, provide the requested information as the patient has already signed a general release form. B, disclose only non-substance related medical information while seeking clarification from legal counsel. C, request a separate release for the disclosure of substance use treatment records before sharing any information. Or D, refuse to release any information as substance use treatment records are strictly confidential under all circumstances. Now, substance use treatment records are protected under specific federal regulations. Which response best ensures compliance with these laws? Okay, if you selected C, that is the best response here. Let's talk about it and go over why. So, unlike general medical records, the substance use disorder treatment records, they are protected under a federal law, specifically the 42 CFR Part 2. Under this regulation, a general release form is not sufficient to disclose substance use treatment records. A separate, specific consent is required before sharing any information related to substance use treatment. This rule applies to all federally assisted programs providing substance use treatment. So the correct approach here is to request a separate release form that specifically authorizes the disclosure of substance use treatment records before providing any information to the primary care provider. All right, so let's talk about these other options so that we clearly understand what's going on here. So option A, providing information based on the general release. So even though the patient signed this general release, the 42 CFR Part 2 requires explicit written consent for substance use treatment records. Sharing this information without specific authorization is a clear violation. Option B, while withholding substance use information is appropriate, seeking legal counsel isn't necessary in most cases. So instead, we would request that separate release directly from the patient. That's going to be the best course of action. And then option D, while substance use treatment records are highly confidential, they can be shared if the patient provides explicit consent. Refusing to release any information at all ignores the patient's right to authorized disclosure when they choose to do so. So this case is a great reminder of the unique confidentiality protections surrounding substance use and treatment. As PMHNPs, we must be very clear about the legal compliance while also ensuring this coordinated patient-centered care. All right, moving on to our next question. So let's shift gears a little bit and discuss research ethics. So an essential area for you as a PMHNP involves clinical ethical studies. So understanding the role of the Institutional Review Board, or the IRB, ensures that the research is conducted ethically and responsibly. On to the question. A PMHNP is preparing to conduct a research study evaluating the effects of a new psychotherapy intervention for patients with PTSD. Before recruiting participants, the nurse practitioner submits the research proposal for IRB review. During the review process, the committee raises concerns about the inclusion of a vulnerable population. Which of the following best describes the primary function of the IRB in this scenario? Options include A, ensuring that the study results will be generalizable to clinical practice. Option B, protecting the rights and welfare of human research participants. Option C, reviewing the statistical analysis plan for accuracy and validity. Or option D, approving funding and financial disclosures for a research study. So think about the main purpose of an IRB. What is its primary role in overseeing research? All right, great job. If you selected B, you're absolutely correct. So the Institutional Review Board, or the IRB, is responsible for ensuring ethical research practices and protecting participants from harm. This includes assessing risks and benefits to ensure participants are not exposed to unnecessary harm, safeguarding vulnerable populations such as individuals with PTSD, children, prisoners, or those with cognitive impairments, and then ensuring informed consent. We got to make sure that this is properly obtained so participants fully understand their rights and the nature of the study. So in this case, the IRB is concerned about PTSD patients as a vulnerable population, meaning extra precautions need to be utilized and are required, such as enhanced informed consent procedures or additional safeguards against psychological distress and reharming. So one thing we want to remember with an IRB, it is human focused. So if you get a question that talks about, discussing animal rights or what's going on with the animals within the study, that is not covered under the IRB. This is for humans. Okay, So let's go over those other questions to make sure we understand fully. Option A, ensuring generalizability to clinical practice. So while this is important and the research should ensure and aim to produce generalizable results, the IRB's primary focus is ethics, not applicability to clinical practices. Option C, research methodology and statistical accuracy, such as that analysis plan. These are important, but the IRB does not act as a peer reviewer for the data analysis. Their concern is whether the study is ethically sound. And then option D, approving funding and financial disclosures. So the IRB, they may review financial conflicts of interest, but funding approval is handled separately. So typically, this is going to be handled by the research grant communities or an institutional funding board. So as PMHNPs, whether we conduct the research ourselves or we review studies in clinical practice, you have to understand that IRB role. Ethical research protects participants while advancing scientific knowledge. This is a balance we must always maintain. All right, fantastic job on that question as well. So that brings us to the end of today's session. Obviously, great job for staying focused and committed to your learning. Now, as we do each week, we're transitioning into our open forum here. If you were at the live session tonight, when you attend, this is your opportunity to ask any questions that you may have. And this can be about challenges in your semester, concepts from the Clarity Review Program, topics you've encountered in your studies, practice questions you've been working through, or anything else that's on your mind. It is an open forum. We talk about it with each other. Other students help other students. And then y'all can ask me as many questions as you want. So hopefully we can find some clarity throughout your studies during the week. And that's included in the actual live session. So this live Q&A session is available exclusively for currently enrolled students through the PMHNP student portal. So just click on the link to join and bring your questions. All right. So before we wrap up, I want to leave you with a couple of powerful thoughts to carry with you throughout the week. Make no little plans. They have no magic to stir people's blood. Make big plans and aim high in hope and work. So this quote is a reminder that growth comes from thinking big. If you're here, you're not just studying for a test. You're preparing for a career that will engage and change lives. So dream big. Set goals that push you beyond your comfort zone. The road ahead will challenge you, but that's how you grow. The magic of motivation comes from knowing that that the work that you put into today is building something bigger than yourself. Don't settle for small plans. Aim high and put in the work to make it happen. I love that quote because it really speaks to the purpose, right? You've chosen a path in psychiatric mental health, and that means something. It means you're stepping into a profession where you'll have the power to heal, advocate, and transform lives. So that idea of the two most important days in your life are the day that you're born and the day that you find out why you were born. That's such a fascinating thing. So every late night study session, every difficult concept you push through, it's all leading you toward that bigger purpose or what you were born to do. Remember, you have to know and remember why you started this journey. That why will carry you through the challenges and drive you towards success. You are all capable of incredible things. Don't let doubt hold you back. Keep working, keep growing, and trust that you're in the right place. We'll see you next Wednesday night at 7 p.m. Mountain Standard Time or 1900 hours. Until then, stay focused, stay inspired, and keep moving forward. Bye-bye.